Let's talk about provider-based clinics. For a chief medical officer, this isn't just some operational tactic. It's a really powerful strategic tool. If you're looking to expand your system's reach and at the same time tighten up your clinical integration, then you absolutely have to understand this model inside and out. So this is the big question, right? The one every hospital leader is wrestling with. How do we drive growth, guarantee quality, and somehow stay compliant with this mountain of regulations? Well, provider-based clinics offer a pretty compelling answer, but the devil is in the details. Getting those details right is what separates a brilliant strategy from, honestly, a compliance nightmare. All right, here's how we're going to break this down. First, we'll look at the big picture, the strategy. Then we'll dive into the nitty-gritty, what provider-based status actually means, the critical rules around location, and, of course, the financial side of things. And we'll wrap it all up with a clear action plan you can take back to your team. So, first up, why are we even talking about this? Well, it's because provider-based clinics are so much more than just another building with your logo on it. They're a fundamental lever for strategic growth. The key here, and this is really important, is to think of these clinics not as satellites, but as true extensions of your hospital. I mean, they operate under the hospital's license, which means they have to be held to the very same quality and safety standards. This lets you project the brand and the clinical excellence of your main campus right out into the community, creating a totally seamless experience for your patients. Okay, but to get all the strategic and financial benefits, a clinic has to officially qualify for provider-based status. And this isn't just a label you can slap on a door. It's a very specific regulatory designation, and it comes with some rigorous requirements that we absolutely have to understand. So let's look at the core definition. The phrases that should jump out at you are owned and operated by and treated as a department. What this really means is the clinic can't just be loosely affiliated. It has to be completely integrated into the mothership hospital. We're talking legally, financially, and clinically. And this right here is where your role as CMO becomes absolutely critical, because that integration isn't just about the balance sheet. It's about clinical and operational reality. You have to be asking, are these doctors credentialed through our main medical staff office? Do they have admitting privileges? Is our quality oversight unified? Are the medical records truly integrated? These are not suggestions, folks. They are core obligations. Okay, so this brings us to some of the biggest hurdles. And let me tell you, the rules around location and clinical integration are super strict. Getting them wrong can have massive financial consequences. First things first, you've got to understand this distinction, on-campus versus off-campus. It might seem simple, but this one classification directly impacts how you get paid, especially with the rise of site-neutral payment policies, which we're going to get to in just a minute. And that brings us to maybe the single most important number in this entire conversation. If you remember one thing about location, make it this one: 250 yards. And there it is, straight from the Code of Federal Regulations. See, this isn't a guideline, it's a hard and fast bright-line rule. That 250-yard mark is what determines if a facility is considered on campus. When you're looking at new sites or thinking about converting clinics you already own, this measurement has to be step one. Now, beyond just where the clinic is, you have the clinical integration requirements. And these land right on your desk as the CMO. It means having the right physician leadership and staffing models in place. And we're not talking about passive oversight. The rules demand active, present medical supervision at all times. And your credentialing process has to extend seamlessly to these locations. All right, let's talk about the money. The financial framework for provider-based clinics is, well, unique, and understanding it is absolutely key to seeing both the opportunity and the very significant compliance risks. This is a huge shift, not just for your revenue cycle team, but for your patients, too. At one of these clinics, a patient gets two separate bills for a single visit. One bill comes from the hospital for the facility fee, that's the UB04, and another comes from the doctor for the professional service, that's the CMS 1500. Your team has to be masters at managing this two-track system. And just when you thought it was tricky, it gets even more complex, especially with Medicare secondary payer situations. As you can see here, if a primary insured just sends one combined payment, you can't just apply it wherever you feel like. You are required to prorate that payment proportionally between the facility and the professional charges before you even think about billing Medicare. Making a mistake here isn't just a billing error, it's a serious compliance risk. And then you have what is probably the single biggest external threat to this entire model: site neutrality.
See, for years, hospitals got paid more for the same service than a private doctor's office. The justification was higher overhead, higher acuity. Well, policymakers are now moving very aggressively to get rid of that difference.
And this is the number that has policymakers' attention. We're talking about $157 billion. That's what the Congressional Budget Office thinks expanding site neutrality could save Medicare over 10 years. With that kind of money on the table, you can bet the pressure to equalize these payments is only going to get stronger.
Just look at this example for a simple joint injection. See that difference? Medicare pays 5 times more for the exact same service if it's done in a hospital outpatient department compared to a regular physician's office. This huge gap is the central target of these reforms, especially for any off-campus clinics that were established after November of 2015. Okay, so we've gone through the strategy, the regulations, the money. Now what? Let's pull this all together into a real, actionable plan that you can use to lead this kind of initiative in your own organization. So here it is, your CMO checklist. These are the 5 big questions you personally need to have answers for. It all starts with that 250-yard rule. Then you've got to have a rock-solid plan for clinical leadership and integration. You need to work with your CFO to make sure billing is ready and that you've modeled the financial hit from site neutrality. And finally, and this one gets missed a lot, you need to review and update your medical staff bylaws to formally bring these new providers and sites into the fold. So what's the bottom line here? Look, provider-based clinics are still an incredibly powerful way to grow and to integrate your clinical services. But you have to recognize that they exist in a really complex, constantly evolving regulatory world. To succeed, you have to be proactive, you have to be detail-oriented, and you have to balance that ambition for growth with rigorous compliance. And that really leaves us with one final big question to chew on. This trend toward site neutrality isn't going away. So as you look to the future, the real challenge is, how will your entire ambulatory strategy adapt to not just survive, but actually thrive in a world where payment is tied more to value and less to location? The analysis that we've gone through today was built on detailed information from these key regulatory and policy sources. Thank you for your time. I really hope this briefing has given you a clear, practical framework for navigating the complex world of provider-based clinics.